ask you to please give your views on consent, and with a particular interest with the COVID crisis, of course. And I welcome Dr. Arvind Kulkarni, who I think was tied up in surgery and has just shown up. He was probably decompressing some cord that Dr. Shinoy was referring to. So I think, Dr. Utture, please, let's hear you.
Yeah, so I think now I should say good afternoon to everybody. And I think after that great talk by Dr. Shinoy, I think majority of us have already passed the first LLB exam, part 1. So he has given you an extensive details of how consent started and at what stage it is now. So he has reduced my job to a great extent. And when he was talking, I have been sitting and removing some of the slides which were there, which he has already, spoken about. So I'll just be talking. A few slides may be repeated, but that is for the practical aspect of what I would be talking. I have divided this talk into 2 parts. The first part is the general consent, and which is going to be relevant, where part 2 will come of what we require to do in this COVID era. I think what was the very first slide, which, and thank you, Dr. Mulaji and Vijlani, for having called me here today. The first slide was consent in post-COVID era, but today we are in the COVID era. And let me tell you, this COVID era is going to go on extending for a minimum, at least for the next 1 year. So let us talk about what we are supposed to do as far as the in COVID era is concerned, because everybody of us wants to go back to work and do our routine surgeries and routine work. So Dr. Shanoy has already, spoken about this, that it has to be what is exactly a consent. It has to be free and voluntary, as he has already told you. I will not go into the details, but what you have to understand is that prior provision of a consent signifies a possible defense against civil or criminal liability. So whatever anybody tells you, let me tell you, a consent is a must. And what type of consent you take is not only going to depend on what type of surgery you are going to do, but also what type of patient you are handling. Because though we spoke about Canterbury and this, it has said in the last line that a day may come when you may have to take the express consent also. And that is what is happening in majority of the corporate hospitals, where they are taking express consent now and not sticking to just the real consent. So what has happened over the years? Doctors are no more gods. There is a great change in the doctor-patient relationship that has happened, and especially because of that advancement of technology. So if you see that Supreme Court judgment which was there, which was asking you to take real consent, was before this era of technological boom that has taken place. Today, the patients go online and check everything and then come to us. And hence, they are quite well educated and they know what is expected of the doctor to do. So if you don't want to get into a legal hassle tomorrow and go right up to the Supreme Court to get anything changed or, save yourself, I think you should take consent in a proper manner. And let us come to see what exactly is the proper manner going to be. Today, the patients know that they have a right, and they have a right not only to choose the treatment, but also the right to choose which type of doctor they go to. So who has the ability to give you the consent? That is laid down in the law. It is 18 years. He has to be mentally sound and not be in a sedated or intoxicated state. I'll come to that in my further slides, why this intoxicated and sedated is the most important thing. See, I'm going to touch upon only the practical aspect. The law point, legal point, he's already touched upon. I'm going to touch upon with my experience practically of sitting in the council for almost last 8 years of what are the problems faced by our members when a proper consent has not been taken. So you see, what are the situations requiring consent? So whichever patient, he has gone into detail as far as what all these are concerned, and what I have put down in red is basically what is most important. If you try to treat a patient without a valid consent, then you're liable for both tort and criminal law. So you can be pulled up in a criminal case, you can be pulled up in a civil case, that is under the Consumer Protection Act, or even a civil case standing, that is a medical councils which are there. So these are the basically what will happen to you if you have not taken a proper consent from a patient. Then, of course, he has already touched upon this. A little bit change I have made in this practical so that everybody understands that implied consent, as he said, as you know, is meant basically for examination and for routine treatment of that patient. But then the next two parts are important. That is the express consent and the informed express consent, as we call it today. So express consent can be oral, can be written. Implied consent, he has already spoken about it, and this importance is going to come. I'll come in the further slides because of the new concept. A lot of questions are being asked as far as telecommunication, which has been allowed by MCI and has been allowed by the Maharashtra Medical Council also today legally. So we'll come to that when I come to that slide as far as what is this type of, because implied consent comes into play over there. But as the last line says, that if there is a slightest chance of any complication, express consent must be taken by one and all. So as far as express consent is concerned, there are two forms. One is that in the oral aspect, that is whenever you know, for body removal of body fluids, or simple example, if you're putting in a Ryle's tube, you don't, or you're putting in a catheter, you don't require an absolute written consent from these patients. But it is always better if you write down on your paper that the patient has been informed that today Ryle's tube is going to be put and he has consented. You may not take a signature, but it is always for your safety, you can put it down on the paper. But if you are going to do anything beyond that, like say for tapping purposes or anything, I think there you have to have a, you know, even for a simple CLW suturing, if you are going to do, you have to have a written consent, because that is what you're doing something actively for that patient. So anything that is invasive, may it be diagnostic or may it be therapeutic procedure, or it leads to any medical legal examination, definitely and written consent must be taken. So as far as the informed consent, I'll go a little bit in detail in this, because this is what is going to be the future, even if it is not there in India today. As we say, we stick to the real consent, but then as the days pass by, and let me tell you, informed consent has been explicitly mentioned in the, you know, Transplant Act. You're supposed to give all the details in the Transplant Act when you take the consent of you know, both the parties. So it is coming informed consent, and that this is going to be what is going to be the future as far as we are concerned. So what it is defined as voluntary acceptance after full understanding by a competent person. That means mental capacity of that person is extremely important, that he understands what he says. If you feel that something is wrong where he will not understand what you are telling, so if he's an uneducated person and you want to explain to him something, a big complication in whatever you're doing, then always have a relative who understands this with the patient. A complete information must be provided. I think that has already been touched upon by Dr. Shana. I will not go into details of that. The voluntary acceptance of the procedure has to be there on the part of the patient. He should not be forced to, you know, accept whatever you say, and should be person and procedure specific. This is most important with the few of the judgments that we have seen, that if you are taking a consent for a particular procedure, unless it is an absolutely life-saving procedure, you cannot go beyond that. And that also, I think Dr. Shana has, you know, already touched upon that. Then a lot of people are asking me, in what format should the consent be there? So it should be a documented consent whenever informed consent is there. And at the end, there has to be a signature of the patient. It is always better to take the signature of the, you know, relatives also who is there with the patient. Then many questions have been asked as far as the video recording is concerned, because that is being done in majority of the corporate hospitals today. Yes, video recording consent you can take, and it is always better to take, because the details of what you talk to the patient in a video recording, you cannot put it down on paper when you are taking a written consent from that patient. But one thing you have to bear in mind, that whenever you do a video recording, the prior permission of the patient has to be there, that you are recording this consent of that patient. So you have to take that prior permission of that patient before video recording. And this is something which is there in all the law points, doctrine of full disclosure. And what is that? So basically that has multiple parts. Number one, that there is an alternative treatment also possible, especially I think a lot of orthopedic crowd is going to be over here today. So are you going to operate, or are you going to treat it conservatively? So you are supposed to give disclosure to that patient of the treatment that you are suggesting, but there are other treatments also, and what are the pros and cons of that other treatment and your treatment. So you are supposed to give full details. And then of course the prognosis and the possibility of the risk factors, and of course here the major risk factors should be told to the patient. So suppose you are doing some fracture or something, shortening of the limb or non-union, all these things have to be mentioned to the patient, and the patient has to be aware of all these problems. Like how, if as a surgeon I'm doing an abdominal case, there could be a burst abdomen, there could be a infection of the abdominal wound. All those things have, in today's era with an educated patient, you are supposed to give all this information to the patient. And of course again the mental capacity and the physical condition of that patient has to be seen whenever you are taking this consent. And when do you take that consent is the most important aspect. Invariably what we do is, in our private practice, we admit the patients in the morning, and of course if your anesthetist has said give a sedation, the sedation is given, and then a consent is taken by your nursing staff or by your RMs. Remember, that is not allowed, because number one, on the day of the surgery or nearing the time of the surgery, mentally the patient may not be in a proper frame of mind to give you the consent. So it is always better to discuss with the patient as far as the consent is concerned when you're fixing up the surgery, so that the patient knows exactly what he is undergoing, what could be the complications, etc., and try to get a consent either on the prior day or before any of these pre-anesthetic agents have been given. So do not take a consent at the last moment, especially when the patient, especially we see this when we are doing any small cases where the patient walks in and you're giving a short GA and doing some fixation or just giving a cast or something like that, and then you take the consent of the patient when the patient is being wheeled into the OT. That should not be the case, because that can go against you in the court of law. Then what are the different aspects? Blanket consent is not valid. It has to be very, very specific. So there was a time, I remember in our residency days, we used to have one single sentence that I am willing for any surgery under any anesthesia, and then he used to sign. No more is that allowed. You have to specify which surgery, what you are supposed to do, everything. Then if there is a repeat procedure, you have to see that you take a repeat consent. A second consent has to be taken. Simple example is that if you are operating a patient and then post-operatively you find that there is internal bleeding going on and you want to take up the patient again. So if the patient is of sound of mind, that means he is not in a very serious condition, a repeat consent of that patient has to be taken if you are going to do the second surgery. Many a times in the council, there have been cases where the patient has said that when there was a complication, we were never told of what the complication is there. We were never told that he would require another major surgery, and a consent was never taken for that surgery. We could have shifted the patient to some other bigger institutes or tertiary institutes. So that should not be the case. Another very, very important aspect of all operative cases is that, remember, there must be a separate consent for the surgical aspect and for your anesthesia care. And this I must insist that all anesthetists, even if that institution does not have a separate printed form of anesthesia consent, please have your own form and take the sign of that patient, because anesthesia becomes a completely different department and the surgical aspect is a different department. You can have complications because of your anesthesia for which you can be pulled up. So consent should be properly documented. That means why I have put down this point is that many a times whenever there is a case coming up in the council, the consent form is produced because if unfortunately there is a mishap, the police come, and the police, what they do is basically they come and they, take away all your papers. Along with that, they take away your consent forms and OT notes and everything. And then many a times what we are finding is that what the sister has done is she has only written the name of the patient on top. Everything else is blank. The fill in the blanks have not been filled, and there is only the signature of the patient below that. So no, what is the type of surgery to be done? Nothing has been written. So this is not a proper documentation of that consent. And I always, a practical aspect I tell all my friends is, you may not take the consent, as already told by Dr. Shanoy, that it can be taken by a RMO, it can be taken by your sister, but get into the habit of signing this consent form before you enter the OT. Because when you sign that consent form, you definitely look at all the blanks that have been left behind, and you have to fill up those blanks before you start the surgery. Then, of course, everybody asks, do you require the consent of a relative? It is not a must as per law. If that patient is 18 years and above and mentally sound, you can have only the consent. But then, to be on the safe side, because tomorrow, if something happens to the patient, for your safety, it is always better to take consent of one of the relatives also. So, having in short told you whatever the practical aspect of consent is there and what we were following up till today, now let us come to this era of COVID. How things are different as far as the COVID era is concerned. And what is the difference? Now, whole management itself is going to be different pre-COVID and post-COVID. And therefore, even your consent, how you take the consent and what you note down on the consent is going to be extremely important for your future. So, what are the differences? What are the deviations that are there in the standard management today? Number one, and most important, that all of us, especially working in small nursing homes or our own setups, is that limited resources that we have got today of both the staff and the equipment. Half our staff are still not yet joined the duty, so it's going to be very difficult. A number of, especially when you're taking high risk patients. Not only that, as far as COVID is concerned, will come in the next slides, that you may be requiring an ICU or a ventilator, which you may not, all the nursing homes do not have unless they are very large nursing homes. So that itself also you have to take into consideration. Then, of course, the risk of nosocomial COVID-19 disease acquired is always there. We will come to that also. Increased risk for your medical staff to especially wherever there is aerosolization, and this is very important. Orthopedics, and of course in any laparoscopic surgery that we are doing, the chances of they getting infected is very high, and we have to take that into consideration in the future also. Then intensive care therapy, that is limited availability is there in the COVID era. Why we require that, I'll come into the next slide, which I'll be talking. I'm just talking about what are the deviations we are going to be facing in the future during this era. Then, of course, technically challenging if conducted in personal protective equipment. Especially, there are cases where sometimes we have to do for 2 hours, 3 hours for a long time. And today, imagine what we are telling all our colleagues is that every patient you have to treat him as if he is COVID positive whenever you are taking him into the OT, and therefore you have to have the full PPE on. And a person who wears a PPE understands how difficult it is to work in an PPE, and on top of them, operating under that full PPE is going to be extremely difficult for us. So that also we have to take into consideration. Both our efficiency, our patience, and everything will go down as that time factor increases. So we have to take that into consideration, and especially in such situations you should have a very good assistance with you. Maybe till date we were doing some surgeries on our own alone, but it's high time, because I have worked in the hospitals also where they are treating COVID patients. Some of our colleagues, within 2-3 hours, even working in a normal COVID ward, they have collapsed purely because of wearing that PPE and getting exhausted under that PPE. That has to be taken into consideration. Then, of course, treatments that render patients more susceptible to COVID disease, especially those who are got high morbidities, like they are on chemotherapy, or they are elderly with high diabetics, especially uncontrolled diabetes, hypertension. That has to be taken into consideration. And of course, the main important point that even today you are seeing that every weekly or every sometimes even every within 2 3 days, even the WHO and ICMR are changing their protocols and their directives that they are giving us, because this is a completely new disease that we are handling. And let us accept that we know very little as far as this disease is concerned, and what are going to be the surgical outcomes, because there are some papers, and I will show you the details also of that, of how even this disease be, I mean, if a patient is positive, how he is affected whenever we do these surgeries. And if the patient contracts or develops COVID-19 while in hospital, recovery from the surgery could be made more difficult with increased chances of serious illness or death. See, you have to understand that the symptomatically the patient becomes positive after about 5 to 7 days. So when he walks into your admission or into your theater, there may be no symptoms as far as COVID is concerned, but post operatively he develops these symptoms. That is going to be an extremely difficult situation for you to handle. I am not talking of your liability as far as the patient getting infected or not in the operation and then suing you. I'm talking about looking after the post operative patient who is going to deteriorate very fast if he is COVID positive whenever you do any major surgeries. And one thing I would like to tell you is, many a times I've been asked this question, that what if the patient becomes positive afterwards, post-operatively, and he blames the doctor. Let me tell you, I have spoken to Supreme Court lawyers and judges about this subject also. The onus of proving that he has got COVID in the hospital is on the patient, which is going to be very, very difficult for him to prove, because he may have got it pre admissions. As I said, the symptoms of the sometimes the positivity when we do a test may come up almost after 5 days of after being exposed to this disease. Not only that, he has got a lot of relatives who are coming and looking after him. He may have got it through them. So there are different factors which have to be taken into consideration, and it is going to be very difficult for him to prove that it is he has got these disease when he was admitted in the hospital. So I don't think we have to bother much as far as that is concerned. Even if you have done the preoperative PCR test and it is negative, you have to understand is that the PCR test has got its own limitations. As they say, even if you take a nasopharyngeal swab, there is almost 35% false negative that can come. And many a times we have found that it has come negative, then after the patient's symptoms have come in and we have retaken the PCR test, it turns out to be positive. So that is also there. So it is very difficult for anybody to prove that you or your hospital has been the cause of him getting this disease. So what is the added responsibilities whenever we are taking this consent? And I've kept this word informed consent, though I know Dr. Shenoy will not agree with me because in India it's not yet come into play. But as I said, we are talking about the future. So let us be ready for the future and let us get into the habit of taking this informed. You don't lose anything by taking informed consent. You may lose one or two patients because you have told them all the details, but I think that is better than losing 10 years of your life, or then you'll have to run to Dr. Shenoy every time to get you save your skin in different forums like the consumer protection or the high court or the Supreme Court. So it is better to be to err on the positive aspect than to try to compromise on taking these consents. So you have to understand the significant scientific, ethical, and moral uncertainties are there when you are treating any patient during this COVID era. So what is expected of you during this era is complete transparency of the potential but unknown risks which are there. So you have to bring it to the notice of these patients that these are the problems that you may face, that I may face during the surgery or post-operative period. So you have to give them all the details, because it is the right of the patient today to know what he is undergoing when he puts his life in your hands. So you have to talk about the risk of proceeding under the current circumstances versus the real risk of delay. And this is what is extremely important when I tell all, even today, I tell my colleagues who ask me, should we start routine surgeries? Like for instance, I am a surgeon and there is a hernia, and especially if it is an direct type of a hernia where the complication is also almost unknown of any obstruction or anything. Why do you want to take the risk of operating such a patient? You wait for some time, wait for 6 months. Maybe once there is some treatment or some vaccination, or we understand this disease much better day by day, there may come a time where you will be, quite in a peace of mind to go ahead and do these surgeries. So if you can wait, you should always wait as far as the surgery is concerned, or you have to take a balanced view. If there is a risk of delay, like for instance it's a malignancy surgery, or suppose he's got an appendicitis or a cholecystitis, there is up to a certain period you can wait, but beyond that you cannot wait. So this balanced clinical judgment you are supposed to take. Not only that, you have to also talk to the patient as far as that the treatment that you are giving him in this era may not be the one which you would otherwise give him before the COVID era. To just give you an example, like we always say that the problems of laparoscopic surgery for a patient and for even the health staff is much higher than doing an open surgery. For the patient, because laparoscopic surgery, he has to undergo general anesthesia, where the complication rate is definitely much more. Suppose I'm doing an appendicectomy, it is easier to do it under a spinal anesthesia than a general anesthesia in this COVID era. Not only that, because of the aerosol problems, chances of you getting infected, chances of infecting your hospital staff, your nursing staff is very high. So maybe doing a laparoscopic appendicectomy is the golden this as far as pre-COVID era is concerned. But then you'll have to explain to the patient that in this era it is going to be very difficult for me to give you this treatment, so I'll give you the next best treatment, and that is an open surgery. So be very transparent with the patient. And let me tell you, I have been operating also during this era, and once you explain to these patients, they agree for getting the surgeries done. Remember, patients go online, and patients find out online that there are there greater advantages of getting a laparoscopic surgery done than an open surgery. But they don't understand that during this era that there are some limitations that are there, even as far as the doctor is concerned. So if you make them understand that, they will definitely be amenable for accepting the treatment modality that you are giving to this surgeon. Then of course, what are the challenges that we are facing? The challenges are that post operatively, the chances of the patient requiring ICU is going to be very high. See, today whenever we take a consent, we rarely ever tell the patient that you will require a post-operative post-operative you may require an ICU treatment, or you may require a ventilator. But today we will have to talk about that, because if you see over there, the second para that is said, that there is, of course, these are very small studies that have been made, because this is a new disease. But there is definitely there, these studies are there where they show that 34 operative patients who turned out to be COVID positive, out of which 44% required ICU care. So imagine today, if are you going to tell the patient that do we tell the patient pre-COVID era that 44 patients, that means almost half your patients may require ICU? We don't tell them. But the time has come for us. You may not say 44%, but that there is a chance that you may require an ICU treatment, and the mortality amongst these positive patients is almost 20.5%. These are documented papers which have come out. So you have to take this into consideration whenever you are taking a consent from this patient. Then, of course, then lack of pre-operative COVID testing in India is something that we have encountered very much. And many of my colleagues ask me that, do you always take pre-operative COVID test done? Yes, in between they had given an advisory that you do not require to take if the patient has no symptoms. But then we have been fighting with the government, and to some extent they have agreed that pre-operative, especially in major surgeries, pre-operative COVID tests must be done. So whichever surgeries you are doing under GA, please do a pre-operative PCR test done. Another thing always asked by my colleagues is, should I go and do an HRCT done? We are finding that if you combine PCR test with HRCT test, almost 94% of the patients can, you may not diagnose, but there is probability that they may be COVID positive. So if you see any ground glass appearance on HRCT, and even if your PCR test comes under the false negative, it is always better if you can wait. I'm not talking about emergency surgeries, which you have to go ahead thinking that they are COVID positive and taking adequate precautions, but which are elective surgeries. Please get a repeat PCR test done, especially if the HRCT is showing ground glass appearance and pneumonitic patches. You get it done, because we have found that the chances of, when you do 2 PCR tests, the positivity rate is much, much higher. Then, of course, the need of ICU in post-operative period must be this, which I've already told you. Sorry, we are on the last line now. So we have to get these COVID tests done. And as much as the government tries, we as surgeons will be fighting with the government to allow us to do these pre-operative tests. Then I think this is as far as the consent and what are the extra things under the consent which we have been taken up till now, and what is the difference that our consent form is going to be, a format is going to be in this COVID era and post-COVID era also. There is not going to be any post-COVID era. Take it from me. We are stuck like how we are stuck with influenza. We are stuck with this virus for life. It may come in, much less virulence, but it is going to come in the future also. So now let me just touch upon another thing, that as far as consultation, that teleconsultation, which has been allowed by the board of governors also, and we have also in MMC, we were the first council to allow a telephonic consultation during this period. So now invariably they ask us, how do you take a consent when you go telecommunication? See, when you give a telecommunication, you don't do any operative procedures at all. And this comes under what we have already discussed, implied consent. The very fact that the patient has taken or come to you on the, either on the telephone, or he has come to you on the WhatsApp media, or a video conferencing that you have done, he has already given you an implied consent for you to treat him. So you do not require to take any special or specific consent from him for doing telecommunication. And you have to understand this 3.8.3 point, where it is written over there that telemedicine practice guidelines are not applicable to the use of digital technology to conduct any invasive procedures remotely. So you are not allowed to do any procedures as far as telecommunication is concerned. So you don't require any very specific consents. It is the same thing as a patient would walk into your clinic and you have examined him and you have given him a prescription for the drugs that you do not take a written consent from these patients, because implied consent is already over there. So someone was asking me, what is the ideal consent? I have seen a lot of consent forms being, and this is one of the consent forms. Of course, I think it is not very clear that is there, but which I found, and I can share it with you afterwards, that which in the COVID era, whatever I have spoken to you, all those details have been put. At the same time, it does not go overboard in trying to frighten the patient. So this type of a consent, if you start taking, and another thing you have to understand is that get into the habit of taking an Aadhaar card from this patient, because that what happens is, today when the sisters take a consent, if I give my name as Shivkumar Utture, or I give my name as my brother's name Anand Utture, you are not going to know, because we do not take any proof from the patients of who they are exactly. So get into the habit of trying to get an Aadhaar card from that copy from that patient, so that documentation is already there. What we are finding is just like how we experience in HIV patients. Many of the HIV patients who are positive, they come to us, but they never ever tell us that they are HIV till we get their HIV reports and we find that they are positive. For some reason, the patients are scared to tell us, because they feel that they will not get the proper treatment, or they may be shunted out if they say that they are HIV positive. And the same case is happening even in patients who are COVID positive. They don't want to tell that in the society, so they will not tell you that they are positive. But once you ask for the Aadhaar card, I have seen that the patients invariably come out by saying, yes, my test has been done and I have been positive. And if he says that and it's not an emergency surgery, you can always wait for that 15 days or 28 days period for him to become negative before he goes for that surgery. And this is the second part. This is a little big consent form. So this is the second part where all these details are also there, and in which we take the signature of the patient, signature of the witness or the relative also, and of course the signature of the surgeon. And what is the importance of the signature of the surgeon? See, today you can take, as per our laws, we can take the signature, the nurse can take the signature, or the RMO can take the signature, because they are part of your team who treats these patients. But tomorrow in the court of law, if the relatives, if the patient has succumbed, or the patient, if he has undergone some complication, he may tell you that I was not told the details of what I am supposed to undergo, and I was not told even the complications which are going to be more than 10% chances. So because then it is a word of your RMO or your sister, and you may find that these cases come up to you after 3 years, 4 years, and that particular RMO or sister may not be there with you also at that time. So it is going to be the word of your patient against the word of a person who is not going to be there for to give an evidence for on your behalf. So it is better that you sign on that, so that you can always tomorrow say that yes, my signature is there. That means I have explained to that patient whatever the patient complications, routine complications which are expected with this surgery. So this is the last slide. What is the take home message? So you have to understand that consent is a legal requirement and not a formality as we treat it nowadays, or we were treating up till now. Getting a mere signature on a form is not a consent. That consent, all those blanks, as I said, have to be properly filled by the surgeon. Then if a patient is rushed into signing consent without giving sufficient information, it may be invalid in a court of law. This is what I was trying to explain to you. Do not take the consent when you're wheeling the patient into the theater or after he has been given the pre-medications. Always take a prior consent when the patient is in the proper frame of mind. Often medical professionals either ignore or are ignorant of the requirements of valid consent and its legal implications. So that is why I congratulated you right in the beginning for having this type of a webinar, which is going to be very important, because you may be the best of surgeons. You may have spent years and decades of your life trying to the best of service to the patients, but one case will destroy you. I have seen good surgeons stopping their practice because of one or two cases which are against them, and what hell they have to undergo whenever they have to attend these courts. So I think we should be, even medico legally, we should be well advised of what we are supposed to do and educated of what we are supposed to do. Then attending surgeon obtains surgical consent from patient, plus additional enhanced discussion has to be taken as far as the potential risks are concerned in today's COVID era, and of course the benefits of delaying an operation during this era or trying to do it immediately. So that also has to be discussed in detail with the patient. Then of course all that I have said is there in this discussion, that what are the general risks, what are the risks of undergoing an operation if infected, or he is pre-symptomatic or asymptomatic positive patient, risk of nosocomial contraction of COVID disease, risk of delays in routine and emergency care, risk of healthcare resource rationing. So all this has to be discussed in today's era, especially whenever you are doing. You may not do this in a minor case, but definitely in all the major cases that you are going to tackle in the future, you have to discuss all these cases. And then of course attending surgeon has to document either in writing or a video document has to be kept, because he has to save his skin in the future during these difficult times. So thank you very much, and I hope I have answered a lot of questions that may be put up in the future.